I'm Dr. John Kruse, and today I'm going to be talking about something is off with off-label prescribing. So as usual, I'll do a take-home message at the start and then get into the body of the talk. So off-label use of medications is any use outside of what the FDA has approved. So that could be using the drug at a different dosage, using it in a different patient population, for example, a different age group or gender, or using it for a different target condition. So using a drug that's been approved for ADHD to treat depression, for example. Results of having an off-label usage being allowed is that for some medications, and this talk was triggered by a recent study on ketamine, we have the bizarre situation where there is a FDA-approved, tightly regulated ketamine product for treating depression, and yet at the same time, hundreds of clinics across the country are using much bigger doses, much longer treatment times, much greater exposure to ketamine in dosage ranges, which at least in animals and at least some human samples suggest could be causing brain damage and cognitive dysfunction. And yet, because these are off-label use, they're not really regulated, whereas a different form of the same drug is tightly, excessively regulated. So I do have a video about ketamine use for ADHD, more focused on depression, and I'll sort of skim over some of that there. Ketamine's an anesthetic that's been around since the 1960s. It has some particularly unique properties as an anesthetic. It does not tend to suppress respiration, doesn't tend to suppress blood pressure. So particularly people who are suffering violent trauma and have massive blood loss, this is a particularly good anesthetic because they're not going to collapse blood pressure further. It's also widely used for pediatric cases where it's harder to intubate, smaller airway, and it's accessibly used in veterinary medicine. I actually used it in some of my PhD research decades ago. Ketamine was around for decades. It started being used at raves as a party drug in the end of the last century. And then in 2000, some studies in humans indicated it was helpful for depression. Within a decade, clinics treating depressed people with ketamine were springing up across the country. Most of those were using ketamine in IV form. Most of those were run by anesthesiologists who were comfortable and familiar with ketamine, most of whom also had no experience or particular desire even to evaluate depressed patients and figure out who was actually depressed and who might have other conditions or indications. So off-label use of ketamine is being extensively pursued. It still is to this day. And in 2019, though, the FDA did approve a specific form of ketamine. So most ketamine in the wild, as it were, is an equal amount of left-handed and right-handed ketamine. What was approved was the left-handed version, Esketamine, as a nasal inhaler and brand name Spravato. It was approved only one dosage size of 28 milligrams, only one dosage size inhaler. People are only allowed to use 1, 2, or 3 doses at a time. So this is not a drug that's allowed to be issued to patients. This is a drug that is sent directly to the doctor. The doctor is required to administer it in the doctor's office. The doctor or their staff is required to monitor the patient for at least 2 hours after taking the dose. And it's specifically because ketamine was identified as having problems with occasional extreme hypertension. That seems to happen only a few percentage of the time. And at the dosages we're talking about here, it also has much more substantial rates of causing hallucinations and dissociations where people feel out of their body or things are unreal. So that's derealization. Those happen close to half of people depending on the dose. Under the REMS, which is called a risk evaluation and mitigation strategy, very narrow range of dosages, has to be administered in place. The patient's name goes into a registry that is kept by the drug company and monitoring for 2 hours. And if the doctor is required to have the space to do it, they're required to testify that they have the equipment, including a pulse oximeter, and blood pressure measuring equipment. If they violate those protocols, they are subject potentially to sanctions. It could lose their license and fines. they could be charged amount of money. However, I should point out that most of the FDA rules and regulations are actually directed at pharmaceutical companies rather than the doctors. Explicitly, the FDA says they're not trying to regulate medicine. They're trying to ensure safe and effective treatments are available. I can testify that in San Francisco, within the first month of Spravato being approved, I had a patient who saw a different doctor and was given the nasal inhaler to use at home. That is a complete, absolute violation. And the doctor had testified that they would not, be using it in that way or form, but they did. They didn't get caught, as far as I know. Spravato is close to $1,000 a dose. So the company does offer a savings program. Some insurance covers it in a limited way. However, with the savings program, the dosing is limited to 24 doses, and each dose is a separate nasal spray. So most people start at 56 inhalations, and most by the third dose, and most is over 80-90%, are taking 3 sprays for each dose. So that's essentially 8 dosages over 24 days. You're limited to taking it every 3 days by that savings program. That's not an explicit part of the REMS, the risk evaluation and mitigation strategy. Again, in contrast to that, if you just go to a ketamine clinic, these days you might get IV ketamine, you might get intramuscular ketamine, you might get ketamine pills that have been compounded. All of these are off-label use when they're doing anything other than being used as an anesthetic. So if they're treating depression, PTSD, even ADHD, other conditions, this is off-label use. And therefore, there's no restrictions on how much each single dose, how many times they can do it. There's no restriction or requirement that they are monitored for 2 hours after each treatment. The worrisome thing pointed out in this survey is that there is fairly substantial evidence both in animal models, rodent models, and primates, but also from humans who are abusing street ketamine. The ketamine at high doses and high frequencies has been associated with specific forms of brain damage, visible on dissecting a brain, and measurable decrements in cognitive functioning consistent with that brain damage. Now, unfortunately, there have been no formal studies over much of the range that is widely used in ketamine clinics, and at least some of that range clearly does overlap with what other evidence suggests is a potentially risky level of exposure. And what's particularly relevant here is that depression tends to be a remitting and relapsing but long-term condition. And there is also significant evidence that at least a small percentage of people who get good antidepressant benefits from ketamine when they attempt to stop it, or when they do stop it shortly after stopping, have severe suicidality. This is not universal, but it's hard to establish how common it is. But most investigators looking at the data say this is a real risk. So it means that for some people, we may be sort of locking them onto a drug, which may be causing damage in the long term. So the FDA started in the 1880s to rein in the snake oil salesmen, the people pushing panaceas and treatments that would cure all your ails. And initially, it was called the Department of Chemistry and the Department of Agriculture. 1906, an agency more clearly resembling the current FDA was established. That was a direct result of Upton Sinclair and other investigative journalists. Upton Sinclair is a guy who wrote The Jungle, contamination, filth, dirt, rat droppings, unhygienic conditions in the meatpacking industry. So the FDA was set up in 1906 to ensure food and drug safety. 30 more years in 1938 that actually efficacy was added to that job of the FDA. So up until then, all they were doing was ensuring this isn't likely to kill you or harm you too badly. But in 1938, they also began to require that drugs showed they were effective for what they were treating. Shortly after that, about in 1940, the FDA moved from the Agriculture Department into what was the progenitor of the Health and Human Services. And again, part of its mandate is that it's regulating the pharmaceutical and food industries, but specifically not regulating the practice of medicine, which is left to the state medical boards. but there's clearly overlap between what drugs are allowed and how you're allowed to use them in medical practice. They don't actually conduct their studies themselves. They ask the drug company to show us data that the drug is safe and effective, and that usually consists of what are called phase 1, phase 2, and phase 3 trials. So in the phase 1 human experiments, it's establishing, is this drug safe in healthy individuals and what range of dosage is safe, and also honing in on what are the likely dosages that are going to be helpful for treatment. Usually fairly small numbers of people, again, including mostly healthy people in phase 1 studies. Phase 2 trials are looking at the effectiveness in treating the target condition. Is it not just safe, but it is actually making symptoms disappear or decrease? And phase 2 is also looking more in depth at what side effects emerge when you're treating people over a period of time. If it's a drug that requires a period of time, phase 3 trials are much larger in scale, so they're looking at a greater number and usually a greater period of time so that they can be more confident about both the safety and efficacy. And I am switching back and forth between efficacy and effectiveness. I know there are differences between them, but I'm not going to get into it in this talk. So when the FDA approves a drug, it is approving a drug for a specific indication at a recommended set of doses and for a specific target population, usually certain age group or certain genders or others. But the off-label use of these medications is officially sanctioned by the FDA. So the FDA says, even though we're saying this is a recommended dose, clinicians, physicians mostly, should use their clinical judgment for what is appropriate for their individual patient, as long as the doctor has reason to believe that the cost-benefit ratio is positive for an individual. They can ignore the dosage recommendations. They can treat someone lower or higher than that. They can use it in a different age group. And this is particularly relevant to ADHD because most of our ADHD meds were first studied in pediatric populations. Some of them, the companies have gone on to do the formal testing required to get FDA approval for use in adult age groups, but some of them didn't, knowing again that the doctors are free to use it as an off-label use. Maybe the most controversial or questionable use is using approved drug for a different indication. A couple of different studies indicate that in the US, probably at least 20% of prescriptions are for an off-label use of the drug. And here, off-label is focusing specifically on a different indication or illness or condition that's being treated. So not outside of the dosage range, not age group issues. And that 20% is almost certainly an underestimate because how they derive that is usually by looking at people with a specific, the FDA recommended or targeted diagnosis to see whether of the people who are taking a specific medication, how many of them have the target diagnosis. Say a person is taking methylphenidate and they have in their chart that they have both ADHD and they have depression. The doctor could be using methylphenidate to treat depression. It's an off-label use, but there's clear documentation that it's effective and quick in doing that. But in most of the research studies, they would assume that this is not an off-label use. The person's really being treated for their ADHD. Other reasons that the data can be inaccurate and underestimate off-label use is that oftentimes doctors don't include all the diagnoses. So they may not include what they're really treating someone for because they know it's an off-label use and they don't want to be caught, even though, again, it is not illegal. But if there's a problematic outcome, then the doctor is at more potential risk if they're using something off-label than if they're following FDA indications. Doctors may be sloppy and omit things. Doctors may intentionally hide off-label use. So again, the 20% is probably an underestimate. So let's look at a few examples of off-label use. One is looking at the family of SSRIs, the serotonin reuptake inhibitors. By the time the company making Luvox fluvoxamine was ready to market it, there was already Prozac, fluoxetine, Zoloft, sertraline, Paxil, paroxetine, all on the market, all approved for depression, all doing quite well sales-wise. These SSRIs are what are called clean and specific drugs. So they are not affecting lots of different neurotransmitter systems. They're very specifically acting as serotonin specifically uptake inhibitors. There are some differences among them, but they are very similar drugs once they get into someone's brain. Again, the first 3 drugs there were already approved for depression. At that time, there was no FDA-approved medication for obsessive-compulsive disorder. So Luvox saw this as a marketing opportunity. They're not going to compete directly as an antidepressant against Prozac, Zoloft, and Paxil. They're going to try to capture the OCD market. It was effective enough in treating OCD to get approval. And in many doctors' minds, Luvox is the OCD drug, and the other 3 are antidepressants. And yet, there is not any research that I've come across that suggests that Luvox is any better than Prozac, Zoloft, or Paxil for treating OCD. It may be for a specific individual, but at a group level, all these SSRIs are equally effective for OCD. They're also equally effective for depression. But again, some of these are targeted, approved use. Some of these would be wind up off-label use. That doesn't make a lot of sense. Another example of off-label use is the non-SSRI Trazodone. It's an older antidepressant that has multiple effects on subsets of the serotonin system. And a couple different studies indicate that 70 to 90% of Trazodone's use is not for treating depression. It's FDA-approved use, but it's used for treating insomnia. Now, there are numerous studies supporting that it can be helpful for insomnia, but none of them are studies that would have been required had the company sought an indication for insomnia. Some experts feel that the data out there doesn't meet criteria that would be needed. Others say that the wealth of information actually does support that this is a good and effective insomnia agent. A talk recently on Amlodipine, antihypertensive. There's some good basic science data suggesting it may be helpful for ADHD. I have another video here on Amantadine, which is originally a drug used to treat influenza. It's one of our first antivirals. For years, it was used off-label extensively for Parkinson's, and it works. And research now is exploring whether it's useful for dementia. The U.S. likes to pat itself on the back for doing things well. Maybe not right now are we patting our government on the back for our government behaving well. And one of the prime case that people bring up is the case of thalidomide. It was a drug that was introduced in the mid to late 1950s. It was used by millions of people, mostly women, because what it was primarily used for, it is very effective at treating nausea and vomiting associated with morning sickness. Something like 70% of women, particularly in the first trimester, do have nausea, and who likes to be barfing? Not too many people, and particularly if you have a developing fetus inside of you, you want to be healthy. Thalidomide was also effective as a calming, soothing agent, so it had some sedative effects, and again, is being used extensively in Germany, Britain, other parts of Europe, Australia, other parts of the world. FDA employee at the time, Frances Kelsey, said that you haven't established that this is actually a particularly safe drug. So she was facing intense pressure. Again, this was selling millions. It was a blockbuster drug, but she was stalling and asking for more clear-cut evidence. And then starting in 1961, a few doctors observed that there was an association between really severe, horrific birth deformities and use of thalidomide, in particular what's called phocomelia. Comes from Greek words meaning seal limbs or flipper limbs, stunted limbs, hands coming out of the chest or torso, abnormal numbers of digits. Thalidomide was also associated with high rates of miscarriages and stillbirths, probably far more than the number of birth deformities it caused. More than 20,000 kids were born in the world with these severe deformities, but in the U.S., because it had not been approved, fewer than 24 cases of such deformities were found in the U.S., and these were people who were involved in clinical trials, suggests that the rate of these deformities was probably about 1 out of 1,000. But again, FDA was lauded as having a big success in keeping thalidomide out of the U.S. market. That's usually where the story ends, but that's not where the story with thalidomide ends. Actually, the FDA in the U.S. approved thalidomide in 1998. You might be saying, oh my God, why the hell did they do that? Were they finally pressured by big pharmaceutical bucks to cave in on it? And the answer is no. It was a reasonable decision because in 1998, there was enough data by the company to show that certain forms of leprosy that were not effectively treated by other antibiotics at the time did respond to thalidomide. And a few years later, similarly, thalidomide was approved by the FDA for treating multiple myeloma. When it was approved, it was only approved under a REMS, a risk evaluation and mitigation strategy. And that REMS required that all women of reproductive years, one, be informed about the risk for deformations, birth defects, and that they be tested to make sure they were not pregnant if they started thalidomide, and continued to be tested depending on the length of thalidomide treatment. So in the US right now, we actually have 71 different drugs on REMS, risk evaluation mitigation strategies, and these are drugs that have a clear use or indication, but also a clearly identified serious risk. There are some drugs, though, that wind up on the REMS list purely for political reasons. So mifepristone, which is the medical termination of pregnancy, the abortion drug, was approved in 2000. Any objective view of the research indicates this is far safer than many, 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 many drugs out there, and that a REMS system is not warranted for it, but that remains there. So some drugs, when they are finally released, are released only in the condition that they have a REMS in place. I should back up, and getting back to the FDA being sort of a regulatory agency armed at the companies. FDA requires that the manufacturer, pharmaceutical manufacturer, comes up with the REMS. Most of those require having a registry, so anyone who is on this drug is on a list the company has. They require that only doctors who show competency with the drug are issued the drug, that usually these are drugs that are sent to the doctor. Some REMS are in place when the drug is released, like with thalidomide. Other times, the likelihood of the side effect is not realized till later. So Accutane, an acne medication, was on the market for 20 years before a formal REMS was instituted. And again, that was a drug that does cause birth defects. Similarly, Clozaril was on the market for decades before a REMS was put in place. So Clozaril is an atypical antipsychotic. In most studies, it is far and away the most effective antipsychotic we have, even though it's an old one. In many cases, it works when other antipsychotics have not. It has some fairly common side effects, drooling, weight gain, that make it undesirable to many people. But the risk or danger is that it also can kill off white blood cells. After it was on the market for years, the side effect was considered dangerous enough and common enough that a REMS was put in place by the company, and doctors had to check white blood cell counts and monitor at regular intervals. But after that REMS was in place for 10 years, the FDA said, okay, we've looked at the data, and what we see, one is this is rarer than we thought it would be. And two, what we see is that the doctors who are using Clozaril are so aware of this potential side effects that they are doing the good work of monitoring appropriately. We're not going to have a required program to limit it. And the other thing is that clearly REMS programs do limit the availability of drugs. So the feeling was that Clozaril would be beneficial to many people who are not taking it, many people who have failed multiple antipsychotics, and that we should make it more available. FDA and DEA have other ways to restrict drugs or try to make sure that they don't cause problems in the general population. So we have this scheduling system. So in the US, we have Schedule I drugs, which are so likely to cause addiction or abuse that they're not approved for any medical use. Those include drugs like psilocybin, LSD, mescaline, marijuana, peyote. Schedule II are drugs that have somewhat lower risk, which includes amphetamine and methylphenidate, almost all the stimulants used for treating ADHD, and most of the opioids used for pain. Schedule 3, 4, 5 are with those drugs with decreasing risk for abuse and addiction. And in the US, most drugs are unscheduled. An unscheduled drug means that an individual just needs a medical license, or in some states, a nurse practitioner license to prescribe them. Whereas any scheduled substance, you need an additional DEA license. But the DEA license is essentially just paying a substantial amount of money. There's no testing or expertise to show that someone really is competent in prescribing stimulants. You do have to document that you're not in trouble with the law, but it clearly sort of reflects that the DEA is more in the business of restricting things and concerned with legal aspects and been concerned about making sure adequate treatment of people's health conditions is taken care of. So when we're talking about restrictions, I mean, it's interesting. Lots of this is politics mixed in. So part of the politics is that ketamine is only a Schedule III drug, and absolutely on pretty much any assessment of dangerous side effects, it is a more dangerous drug and probably at least as prone to addiction as peyote, mescaline, psilocybin, LSD. And yet, those are all Schedule I, ketamine's Schedule III. Another big example is something that's not even considered a drug is alcohol. Other than having an age of 21 or over to buy it, alcohol use is pretty unrestricted in the US. And as a consequence, we kill more than 187,000 individuals each year from excessive alcohol consumption. That number is substantially higher than even at the peak of the opioid epidemic. All the people dying from opioids, all the people dying from every other illicit drug available on the market. It's not including nicotine deaths. Assessments of when we did try to limit alcohol, so prohibition ran from 1920 to 1933. The 18th Amendment established prohibition, banning the sale and manufacturing of alcohol. 21st Amendment, a little more than a decade later, repealed that. And it is always described as a textbook failure, that particularly over time, it was widely flouted. There are people making moonshine, people smuggling in alcohol, and that there seemed to be a substantial rise in organized crime associated with it. But if you actually look at what prohibition was put in place to accomplish, it absolutely substantially decreased rates of alcoholism. It substantially decreased deaths related to alcohol problems. So by some measures, it was a clear success. And whether it was a success or a failure overall is dependent on your values. It's not a matter of fact. We can't resolve it because it involves weighing what you consider important and what values you want to preserve. So the libertarian approach to drug control and management is to put no restrictions on medications. And the result, an extreme libertarian approach, there is much more access to medications and many more people dying from side effects and deaths. And also the consequence, many people taking ineffective medications because they're willing to try things which have not had established records for being success. And along those lines are many people who took ivermectin or hydroxychloroquine to treat their COVID or prevent their COVID. And most of the research shows that those are largely ineffective measures. The other end of the spectrum is an authoritarian approach where the government extremely limits access, and presumably fewer people are getting into problems with medications, but it means fewer people who might need it or benefit from it have access to those medications. Separate from sort of which philosophical approach, our current system has this major incompatibility where the exact same substance, if some forms of it are available under a tightly regulated, restricted REMS system, and others are off-label, that just doesn't make much sense at all. One of the proposals, and this is mostly to address the issue of off-label use of medications and not knowing whether the drug's really effective. So a group of pharmacists made a proposal. They suggested the government should monitor off-label use of each drug where this is prominent. And whenever annual off-label sales equal the amount that would require to do a thorough sort of FDA-approved phase 3 testing, which is about in the $20 million range, then that company should be required to pony up the money, spend it on showing that the drug is really effective for that use. In their minds, that would at least solve the problem of using off-label medications for situations or conditions where they're not really effective or appropriate, but nobody's done the testing. This is one of the government messes that I do not think is going to be readily solved in the next year or 2 or 3. particularly by the current administration, but hopefully you've learned something about what off-label prescribing means and why we have REMS programs and how they work. That's all. Stay healthy, stay happy.